Right, hello, everyone. Welcome to the event, the Sir James Mackenzie Memorial Lecture, um, brought to you by the New York Chapter and Society of ACC. As a reminder to all attendees, please keep your camera and microphone off during the event. If you have any questions, please put them in the chat. And I am so happy to welcome Dr. Narula and Dr. Kim as our event moderators for today, and I will hand it over to them.
Thank you so much, Taylor, and welcome to everybody. We're so honored to have Dr. Pierre Elias with us today. He's an assistant professor in the Division of Cardiology and the Department of Biomedical Informatics at Columbia, where he practices as a general cardiologist. He's also the medical director for artificial intelligence at New York Presbyterian. His research lab develops machine learning technologies for medical imaging to improve the detection and management of cardiovascular disease. Dr. Elias received his medical degree at Duke. He completed his residency in internal medicine and his fellowship in cardiovascular disease at New York Presbyterian Columbia University through the clinician scientist pathway. He completed his postdoc under Dr. Adler Perot in the Department of Biomedical Informatics. He's been named a Stat News Wonderkind, highlighting 20 of the most innovative junior researchers in the country, and has received the Emerging Generation Award from the American Society of Clinical Investigation. He was previously a data scientist at Lumiata, helping develop Google's Knowledge Graph for Health. We're so honored to have him, and I'll hand the stage over to him. For any questions for the audience, please do write these in the chat box, and we can go through them at the end. So thanks so much.
Thanks so much, Dr. Narola, and thank you all for being here. I have one goal, which is for you to not feel bored during this talk. I think we see AI everywhere in our lives right now. It's pretty dizzying, and it feels like a big change. And I think they're really genuine and open questions about what does this mean for our careers and how we can practice medicine? And should we be optimistic? Should we be pessimistic? Is the jury still out? And my hope is that this talk will engage you in some of those questions in real and practical ways, and that at the very least, you will find it engaging and entertaining. So these are my disclosures. I want to start with how I became interested in this topic and the beginning of my journey. Years ago, I was staffing the cardiac ICU overnight, and I got a phone call from an outside emergency department. A patient had presented to that emergency department 3 months prior with chest tightness and shortness of breath. And they had ruled them out for an MI, and they said, we do think you should follow up with your primary care doctor. You have a murmur, you should get that checked out. Life got busy. He made the appointment with the primary care doctor, but it hadn't happened yet. 3 months went by, and he showed up back in that same emergency department with those same symptoms again, chest tightness and shortness of breath. This time, though, he was in respiratory distress. He ended up getting intubated, and they transferred him to their ICU. And in the ICU, they did a quick echocardiogram, and they showed that he had critical aortic stenosis. And so they were calling us at Columbia for an urgent transfer because they were really worried about how sick he was, and because we have expertise in valvular heart disease. I said, absolutely, send him over immediately. I ended up spending the rest of the night working on the patient, but by the morning, he was in multi-organ failure despite being on ECMO and Impella and CVVH, and he passed away later that week. And he was a gentleman in his early 60s with no past medical history. He was otherwise quite healthy. And I knew two things were true. The first was there had not really been a missed step. There wasn't some laboratory test that they ought to have ordered that they hadn't. And the second was if we just knew about this disease, he could have gotten a same-day outpatient procedure, and I think he'd be alive today. And it really burned into my mind this fundamental truth, which is you can't treat the patient you don't know about. Everyone on this call does a fantastic job of taking care of patients once they've presented. And there are still plenty of challenges that exist there. But really, one of the foundational things that we struggle against in medicine is how do we get the patient to the right diagnosis, the right treatment, and the right provider at the right time? That problem is only going to get harder. We're going to have fewer doctors, an older population, and more people who are sick. That's just the reality of where we are headed as a society. And so we have to fundamentally rethink care paradigms. And we have to find new ways to provide even better care than what we're providing today. So the question is, can AI help? I'm proud to say that today I run the largest cardiovascular AI screening program in the country. And over the last 5 years, we've really grappled with a number of these questions. And so, what we're going to talk about today is the ways that AI can impact cardiology in the discovery of disease, the diagnosis of it, and lastly, the enduring clinical impact it can have. So the first thing is, where does AI or machine learning or deep learning, and I'll use those terms interchangeably in this talk, where does it actually make a difference? There's a lot of times where you really don't need AI, right? There's a lot of times where a traditional statistical model will work just as well. So where are the places that AI can make a big difference? So I think the two areas are imaging and complex language. So for both of those domains, all we've had up to date is human interpretation. And so the visual cortex of the human brain is an amazing pattern recognition device, but it is flawed. And all I have to do to prove that to you is tell you that all of these gray lines running horizontal in this picture are parallel to one another, even though your brain is telling you they're not. We have a pattern recognition device, and it's great at picking up certain patterns, but it's not so great at picking up other patterns. For the first time in human society, we have a complex and robust pattern recognition device for visual information and complex language that is not the human brain. And that is really at the heart of all of the innovation and revolution we've seen with AI over the last 10 years. And the second thing is we have a huge amount of data that's really being left on the table and underanalyzed or underutilized. A single CAT scan is the equivalent of, the entire electronic health record data for, 500 patients. And we all know a single good note is better than 500 garbage ones. So how do we most effectively use those rich sources of data that are probably being underutilized today? And lastly, these are domains where traditional statistics are really poorly equipped to analyze the data. So for a long time, the paradigm in medical AI research has looked something like this. You are building an AI model to detect pneumonia from a chest X-ray. And so you're using human expert interpretation as the gold standard. And you have a current state of model where, let's say, the current AI model is 70% as accurate as the human expert. And then you built a new model and it's 80% as accurate as the human expert. And so the idea here is you're building new models to get closer to the expert than the old model. Our work flips this on its head. We say that there are a number of really important clinical outcomes that humans cannot predict well. And so instead, what if the gold standard label we try to learn from is actually a more accurate but more expensive diagnostic test? And then we say, well, could we actually look at that information and could the AI model outperform a human expert? So let me give you an example. Based off of my experience with that patient, one of the first things we built was this model called ValveNet. So as we all know, valvular heart disease is too often missed. And the reason for that is because we diagnose valvular heart disease with an echocardiogram, which is a very expensive test. And because it's expensive, it's very often symptom driven. We wait until patients develop symptoms, which only happens late in the disease course. And because the symptoms are vague, like shortness of breath, patients are going to show up and who knows if they're actually going to get referred to a cardiologist and get an echocardiogram done versus a variety of other tests. We asked ourselves, though, could we detect valvular heart disease from an electrocardiogram? Electrocardiograms are ubiquitous. We do about 400 million of them around the world a year. But we were all taught in med school and cardiology fellowship that you can't detect valve disease from an electrocardiogram. So instead, what we said is, could we train an AI model to look at patients who had both electrocardiograms and echocardiograms and then detect patterns on the ECG that were predictive of patients with moderate or severe valvular heart disease? And we had no idea if this was going to work. In order to do this, we had to get a lot of data. And so we ultimately ended up building the country's largest cardiovascular imaging database here in New York. So this includes all of the data across all of New York Presbyterian's 8 clinical centers and 180 clinics. This is over 12 million electrocardiograms, 1.5 million echocardiograms from 8 hospitals. And all of this data has been sanitized, tokenized, validated, harmonized. What do I mean by that? I mean, whether you read using Singo or Accelera for your echo reports, whether you do quantitative ejection fraction or visual estimation, we actually went through, we clinically validated all of this data, and then we organized it so that it actually lives in a single centralized database and is regularly updated with everything that happens so that we could look at a longitudinal pattern of a huge amount of data going back well over a decade for over 2 million patients. And the impact is we were able to publish one of our first papers. This came out in JACC a number of years ago, where we showed, lo and behold, you could detect moderate to severe aortic stenosis, aortic regurgitation, and mitral regurgitation from an electrocardiogram with a high degree of accuracy in a held out test set. So this was really exciting. But I, as a clinician, I still hold prospective validation as the gold standard we should all be attempting to achieve. So we said, all right, this works great in a held out population of retrospective data. But if I'm going to believe this, I want to prospectively test it. And more importantly, are there patients out there who are actually being missed who we could help with this technology? So the next thing we say is, okay, we need to run a clinical trial and we need to be able to recruit patients. And in 2025, this is literally the elevator bank outside of my office. This is still how so many clinical trials do recruitment, right? Hey, are you 18 or above? No recent medical x-rays. I'll give you 20 bucks if you come in and let us do an x-ray on you. This is not a scalable or effective way to run a trial, nor is it a way to get to the patients who most need you. And so we had to fundamentally rethink the way that we engage in clinical trials and recruit patients. So we ended up creating a real-time recruitment platform. So instantaneously at all 8 hospitals and 190 clinical sites, any data that is generated across vendors and modalities is automatically captured, transferred into a cloud model where we're able to pre-process that data, and then we run a variety of different ML models on that data, and then deliver that information to a number of clinicians, clinical trial coordinators, and administrators so that they're able to effectively go and enact care in the light. We've now run this live on over 1 million patients in the last 2 years, and we are currently in the process of, I think, running our ninth, 10th, and 11th clinical trial using the platform. And so this really allowed us to start to understand, like, what is the true impact of it? And for anyone out there who's excited about doing this work, you don't have to wait. The very first version of this platform and of the technology was an Excel spreadsheet that got emailed to clinical coordinators every morning at 9 a.m. with the new high-risk patients. Over time, we made it more sophisticated and we added Epic integration. But so important to the start of the work was, were we answering an important and meaningful question, and were there actually patients who were being missed who needed our help? And we didn't want to wait around years and years and years to find out if those things were true. And so it's okay to have a bare bones version 1 that you work with, and then say, we'll make it more sophisticated. Try to convince the people in your local environments that we'll figure out the details as we go on, but let's understand, is this actually genuinely impactful? Can we do a QI study? Can we do a pilot study? Can we just try this out before we say it has to comply with every standard and the 17 new committees that have probably popped up in the last 2 years at your systems? And I think it's important to try to iterate quickly and figure out, like, are we answering a meaningful and important problem? And is there evidence that there are patients who need our help? I think this is probably the most important slide in my talk, if you take away nothing else. This is a paper that came out in JAMA last year by Bob Wachter and Eric Brynjolfsson. Bob is the chair of medicine at UCSF. He's a past mentor of mine. Eric is an economist at Stanford. He was at MIT for years. Eric has spent his career studying this thing called the IT paradox, which is, in all of these different industries, they will be due for some sort of like information technology revolution. And that revolution will be coming through, a new stack of technology, and everyone's really excited. And they expect there to be these massive productivity gains. And then sometimes there is, but oftentimes there's not. And the question is, why does that happen? And Eric describes it as the two key hypothesis, which means you need two keys in order to unlock these massive productivity gains with new technology. The first is the technology must be sufficiently better than what we do today. And I can say confidently that in specific domains, AI is sufficiently better than what we do today. It is the second key that will be our stumbling block and will decide our fates, which is, are we willing to reimagine the work itself? So what do I mean by that? If we look at something like software engineer, and we look at what software engineers were doing 10 years ago or even 20 years ago, it is drastically different than what the job entails today. If we look at what physicians were doing 30 or 40 or 50 years ago, in a lot of instances, it's very much the same. You could take a physician from 100 years ago and drop them into a modern hospital, and they would still know what all of the locations are. They would say, oh, that's the operating theater, those are the wards, this is the intensive care, those are nurses, those are doctors. And the fact that there has been so little transformation in medicine is something that we really have to grapple with. And I will say, if you look at the industries where there has been very little evolution in the way the industry functions, there's really three large ones. It's education, housing, and healthcare. And what happens is when you don't have significant innovation over time, the cost of labor goes up, but you're not making the rest of the system more affordable. And if you look at what are people in the United States spending more than half of their income on, it's education and childcare, housing, and healthcare. And so this is something we have to genuinely reckon with. And my job as the medical director for artificial intelligence and as someone who believes in this technology is to practice cardiology in a way that is different than how I was trained. And it is something that brings me discomfort, but is important to do and study so that we can understand, is there going to be a new way to practice medicine and specifically practice cardiology? And is it ultimately better for patients and better for clinical care overall? So I think what I'm going to show you will be some pieces of information today that may make you feel uncomfortable. And I hope we have the opportunity to have a conversation about that. But I think are meaningful and exciting and lead to possibilities of providing care in entirely new ways for patients. So I became obsessed with this question. We have no screening test for the most common cause of death in the world. We have mammograms, we have colonoscopies, we have pap smears. We have no equivalent for most forms of cardiovascular disease. And the reason for that is relatively straightforward. The way we diagnose most forms of cardiovascular disease today is either too invasive or too expensive to do on a population level. But electrocardiograms are cheap and ubiquitous. And so I asked myself, of all the people out there with an electrocardiogram and no echocardiogram, who needs an echocardiogram? Could we use a cheap and ubiquitous test as the front door to cardiology and as a screening test for all forms of structural heart disease and cardiovascular disease? And so we ultimately built a foundation model that looks across all forms of structural heart disease. So this is called EchoNext. So this is an AI model that looks at electrocardiographic waveforms to detect all forms of structural heart disease. So the primary output tells you, should you get an echo on the patient or not? But when I say structural heart disease, I mean LV dysfunction, RV dysfunction, moderate or greater valvular heart disease, severe LVH consistent with infiltrative cardiomyopathy, pulmonary hypertension, pericardial effusion. That represents over 98% of the diagnoses we make by echocardiogram. And this was the first time that we had built a foundation model that was looking across all of these diseases, making individualized predictions for the diseases, as well as a composite prediction for structural heart disease. And this model was trained on 800,000 ECG and echocardiograms from 150,000 patients. And I'll show you the results in just a second. But this ended up being our seminal paper published in Nature earlier this year. So we validated this model at 11 hospitals, 4 health systems in 2 countries, and we saw excellent performance across all clinical sites. regardless of community hospital, tertiary medical center, academic medical center, regardless of race, ethnicity, or gender. We then followed 85,000 patients for the course of a year who were getting an EKG and had no prior echocardiogram. And we ran the AI model on all of those patients, and then we followed them for a year to see what happened in routine clinical care. So the AI model predicted 9% of those patients as high risk for undiagnosed structural heart disease. If you follow those patients for a year, about half of them will go on to get an echocardiogram, and the positive predictive value in those patients was 74%, which was 2 times the positive predictive value of all first-time echoes being ordered in our system. The really stunning thing, though, was half of the high-risk patients showing up in our health system don't go on to get an echo. So we are missing half of the new structural heart disease diagnoses that are presenting in our system. We then ran a clinical trial where we recruited 100 of these patients, and we found that amongst these patients, there was the same positive predictive value as we were seeing in the prospective observation group. Lastly, we had 13 cardiologists from around the country read 3,600 electrocardiograms with and without the AI model. And we asked them, does this patient have structural heart disease or not? And so what we saw was when the cardiologist was reading the EKG alone, their accuracy was 64%. When we gave them the recommendation of AI, it went up to 68%. And then the AI model's interpretation alone was 78%. And this was a yes/no question. So baseline random chance is 50%. So that means I, as a cardiologist, am as far away from random chance as I am from the AI model. And this was really humbling. You know, myself and my co-creator, we took the survey as well. We recused ourselves from the results. But even I, as the person who built the model, was no better than all of the other cardiologists from around the country who we asked to run this. So we're now starting to see evidence that AI models can exceed human expert performance in certain use cases. Okay, maybe this is just the problem with the cardiologist, right? We're an arrogant bunch. Maybe the radiologist will do better than us. So this was some of our work looking at chest x-rays. So, you know, the only thing that we ever see the radiologist say about the chest x-ray is cardiomegaly, right? And that's not a useful diagnosis. It doesn't lead to a clear next decision point. But we all know that heart failure is a huge issue. And before patients develop symptomatic stage C heart failure, they develop stage B heart failure, where the heart thickens and dilates. And so we asked ourselves, instead of saying cardiomegaly, could we get to a point where we actually say that, hey, this is a patient with severe LVH or dilated left ventricle based off of the chest x-ray? So we trained a model, we then validated at Stanford, and then we had 15 radiologists read head-to-head against the AI model. And we found the exact same thing. The AI model outpredicted all 15 radiologists, you know, whether they were general radiologists or thoracic radiologists, in the ability to detect severe LVH and dilated left ventricle from a chest x-ray. And so we're seeing the same thing again here. And we published this work in European Heart Journal, and we actually made this entire data set publicly available, all 75,000 chest x-rays with echocardiographic pairs, so that other people could build off of this work. Okay, so we have built these new AI models. They've done a great job of detecting who should go for an echocardiogram, and, you know, mission accomplished, right? Once they get an echo, everything should be really smooth from there. Well, you know, I had a patient come and see me, and I said, you need an echocardiogram. And he said, Doc, don't worry. I just got an echocardiogram done down the street, and I'll bring you the echo report. And this was the echo report that he brought in. And you know, I remember posting this on Twitter, and Mark is an interventional cardiologist down in Virginia, and you know, I think he had the best quote. And I think this really is emblematic of another challenge we know exists, which is there's huge inter-reader variability in the quality of interpretation and the quality of acquisition of data. So we asked ourselves, could AI help us with echo interpretation? And specifically with the things that we consider to be the most challenging part of the work that we do, which I think is valvular heart disease and specifically around regurgitation, right? I think quantification of regurgitation is an extremely difficult and variable task for us. So we said, let's give it the hardest task. Let's see how we could do in detecting mitral regurgitation and effectively classifying it. So we built an AI model that looks at echocardiographic data and then determines what is the severity of mitral regurgitation that exists on the echocardiogram. And we developed the model at Columbia, and then we validated it at Cornell. And what we saw was 96% agreement with academic lab interpretation. And then the 4% of the time that it disagreed, we found that about half of those cases, the AI model was correct and the human interpretation was incorrect, based off of blind adjudication by 3 cardiologists. We're now actually running a prospective clinical trial, and I'll talk a little more about it, where every echocardiogram at Columbia is reread by AI models. And when there is a significant discrepancy in mitral regurgitation, tricuspid regurgitation, aortic regurgitation, or aortic stenosis, that then gets sent to cardiologists to blindly adjudicate. We've been running that clinical trial now for the last 4 months. But this work we published in Circulation in European Heart Journal over the last 2 years, basically showing that there's a growing body of evidence that these models can actually do a really great job of taking these very difficult tasks and at the very least providing an additional read on what we think the level of disease is. And so whether it's catching missed cases or providing a clinician with a second pair of eyes, we think this is something that could be very, very helpful in making sure that patients get adequate classification and appropriate treatment based off of it. Lastly, I want to talk a little bit about cardiac amyloidosis. So this is a disease we all know about. It's one that we're very near and dear to us at Columbia and NYP. We were involved with the development of the pyrophosphate scan, the non-invasive way of detecting cardiac amyloidosis. Matt Maurer, who's a mentor of mine, wrote the first New England Journal paper of a treatment for this disease that showed a mortality benefit. And the sneaking suspicion we have is that there are many more patients who remain undiagnosed with this disease. And we're living through a golden era now of there's so many treatment options available for these patients that finding them and finding the needle in the haystack is really the challenge that exists. So we built another AI model. We built a model that looked at ECGs and echocardiograms to accurately detect cardiac amyloidosis. And same thing, we started with a retrospective data set, and we found that the model had really excellent performance in detecting cardiac amyloidosis. And then Matt came to me and he said something interesting. He's like, listen, I know that this disease should have a preponderance in Black and Caribbean Hispanic patients, but when I look at my clinic, it's almost all white people. What's going on there? And I said, well, that's interesting. Let me look into that for you. And so what I did is I looked at what was the relative proportion of white, Black, and Hispanic patients in these different sectors. So if we look at patients who just show up at our doorstep at Columbia, it's about 46% white. If you look at who gets an EKG, again, it's around 43% white. Echo, slightly more expensive test, about 52% white. And then you looked at who was getting pyrophosphate scans, the way we diagnose cardiac amyloidosis, and it was 80% white. So the upshot here is the people we send for advanced diagnostic testing are twice as white as the general population we care for. And I don't think anyone is actively being biased. I think the reason this is important is because when people talk about AI having bias, there's absolutely a risk of AI having bias. But we have to recognize and acknowledge we're starting from a place where there may be systemic issues that exist today that AI could potentially help with if we implement it in a smart and thoughtful way. So we then asked the AI model to look at a number of patients who are at high risk of undiagnosed cardiac amyloidosis. And we said, which of these patients do you think are positive for undiagnosed cardiac amyloidosis? And if we look at who the AI model would recommend would go for advanced diagnostic testing, those patients are 54% white, 16% white, and 31% Hispanic. So much more representative of the population that exists in our health system. And so this was something that we thought really could show that there was a meaningful way to change referral patterns using these technologies. So we wanted to put our money where our mouth is. And so we just recently completed the cardiac amyloidosis discovery trial. This was published in JAMA Cardiology a few weeks ago, and we presented this as a late-breaking clinical trial at American Heart Association. So this was a single-arm, multi-site trial within a single healthcare system. This involved all 8 hospitals, so academic, community, with a really wide variety in racial and ethnic populations. Columbia is majority white and Hispanic. Queens Hospital is majority Asian. Brooklyn Methodist is much more white and African American. And so a real wide diversity in racial and ethnic blends across the population. So the inclusion criteria is the AI risk score had to say that you were potentially at high risk for undiagnosed disease using electrocardiograms and echocardiograms within the last 2 years. You had to be over 50 years old, and you had to have an LV wall thickness of 12 millimeters or greater. And then if you had uncontrolled hypertension or aortic stenosis, you had to have a wall thickness of 14 millimeters or greater. You could not be a patient. The exclusion criteria included any patients with any form of prior evaluation for cardiac amyloidosis or plan for cardiac amyloidosis. So all of these patients had to be ones where we genuinely had not thought about testing them for cardiac amyloidosis. They couldn't be patients who were nursing home residents, had dementia, or a lifespan of less than 1 year. So these had to all be patients who we would put on treatment if we discovered that they had disease. No prior heart transplantation or a clinical diagnosis of hypertrophic cardiomyopathy. So the idea here was to screen our patient population and figure out, are there patients with treatable cardiac amyloidosis who are otherwise being missed in the system? So the primary outcome was a cardiac amyloidosis diagnosis by multi-society criteria. And then we had 2 comparator groups. We looked at the prior year and all patients who underwent amyloid scintigraphy within that year, as well as contemporary controls. Because cardiac amyloidosis is changing, we didn't want it to seem like we were just diagnosing more people or getting better at cardiac amyloidosis testing, and that is the reason the AI model was doing better. So we looked at both historical and contemporary controls to determine what was the baseline rate of positivity, how many patients were being diagnosed within our system, and determine what was the positive predictive value of referral by AI, as well as the absolute increase in diagnosis due to AI technology. So we had 1,471 patients who were flagged as positive based off of the AI risk score. About 250 of those patients were excluded because of a prior diagnosis or testing for amyloidosis, 230 because of dementia or nursing home residents, about 700 because of life-limiting disease, where we didn't think they would be good candidates of treatment. We were left with 256 patients we wanted to put in the scanner. We ultimately got 50 of those patients. So what happened to the other 206 patients? So the first issue was nearly 50 times a physician just never responded, and then another 31 times the physician declined. This was despite a patient being high risk for an undiagnosed disease where they need a specific treatment, and they would essentially live for 4 years longer on average if they were placed on treatment. And so communication paradigms for AI technologies are a real challenge. And building trust with physicians is super crucial. There's also an open question here, which is, if I think a patient has an undiagnosed disease, do I have the rights and privileges to go directly to that patient and if a physician doesn't respond to my request? And I think it's an open question from an ethical standpoint. The second other major reason was patients declining. And it was a similar degree of suspicion. Patients saying, well, I don't know what to think of this AI test and all this thing, and we're really suspicious of it. And so what we see here is there's a huge amount of work to be done about building trust with these technologies, both for patients and for physicians. So I want to start with, what was the rate of positivity for historic and contemporary controls? So we can see in both 2023 to 2024 and 2024 to 2025, if you look at cardiologist referral for cardiac amyloidosis evaluation, across our health system, we send about 900 patients for testing, and about 130 to 150 are positive. So in both cases, 15% of patients were positive. patients who were referred based off of AI analysis, 48% were positive. This also led to an approximate 20% increase in new diagnoses across one of the world's busiest cardiac amyloid centers. If we had actually been able to get all of these patients into the scanner, we would have likely doubled the total number of patients diagnosed with the disease at our system. On top of that, we looked at when was the patient first being flagged as positive based off of the AI model. Because I think a critique you could say is, well, what if this patient just got referred into your system and no one yet has been able to act on it? On average, these patients were flagged 345 days before we put them in the scanner. And so you could imagine they had already been flagged as positive and they'd been sitting around on average for a year before we were able to actually get them into the scanner. And so these are not patients who are just showing up in our system and we're catching very quickly. There's actually significant patients who are sitting in our system and otherwise being missed. And this could also potentially help with getting patients to diagnosis earlier. We also looked as a secondary analysis, did any of the patients have AL? And none of the patients were diagnosed with AL. I apologize. 88% of the patients were started on treatment at time of presentation. So earlier I had talked about EchoNext. This was our AI model that looks at ECGs and tries to determine who has undiagnosed structural heart disease and should go get an echocardiogram. So what are we doing there? We are, with the support of the NIH and Edwards Lifesciences, running the largest cardiovascular AI screening trial in the country across 8 emergency departments in the greater New York area. So this is going to involve 54,000 patients who are being screened by the AI model, and approximately 3,000 to 4,000 patients who will be included in the trial itself. And the way this works is every patient who presents to the emergency department and has an electrocardiogram done and has no prior echocardiogram will then be evaluated by EchoNext, the AI model. If their electrocardiogram is flagged as high risk by EchoNext, we then alert the provider that this patient is at risk for undiagnosed structural heart disease. And then based off of how they respond to that alert, a number of things can happen. We can say, hey, this is a patient who doesn't need to undergo an echocardiogram for a variety of reasons. Or if they ignore the alert, we then take over and then make a determination of if it's clinically appropriate to get an echocardiogram on this patient. And then we'll either get an inpatient or an outpatient echocardiogram on the patient. And then we'll follow up with that patient at 90 and 365 days to look at the number of new diagnoses of structural heart disease, as well as the rate of new class 1 or 2A interventions for those patients. And so this will be a cluster crossover study involving all of the sites. So all sites will spend half the time on AI treatment and then half the time on usual care. Probably the first thing you might take away from this is extremely complicated. And we realized there were so many moving parts that we had no idea how to do. How am I, as a cardiologist at Columbia, supposed to order echoes at 8 different sites? What do the referral patterns look like at these different sites? How do we make sure that these patients get appropriate diagnosis? And what % of patients are going to respond and pick up the phone when we call them and say, hey, we think you need a follow-up echocardiogram based off of your recent electrocardiogram? So that led us to run the Cactus pilot for the last year. And we just presented these results at TCT a few months ago. And so I'm excited to share these with you. So we had a simplified workflow during the Cactus pilot. Essentially, any patient with a high-risk EKG and no prior echocardiogram would come to our team, and we would then evaluate, was it appropriate to get an echocardiogram on that patient at the end of their clinical encounter? So essentially, this patient would either be getting discharged from the ED or admitted to the hospital and then discharged from the hospital. And if at the time of discharge, they had no echocardiogram and no plan to get an echocardiogram, we would then evaluate if it was appropriate to get an echocardiogram on that patient, and then intervene and call the patient, get them scheduled for an echocardiogram, and then follow up on the results. So this is really this idea of a centralized champion model, of screening all of the patients in a health system, patients I've never met before, making a determination quickly based off of chart review that they would be clinically actionable if positive for disease, then getting them booked at an echo at 8 different sites, 7 of which I don't practice at, and then making sure that we follow up the results and then getting them plugged into care at their local site. So what were the results? 3,500 patients with high-risk EKGs by AI analysis were assessed for eligibility. We excluded 2,346 due to having an echo within the past 2 years, a prior structural heart disease diagnosis, or quality of life issues. That led to 1,152 patients who we called, and 317 of them underwent echo due to AI intervention at the time of this interim analysis, which was 90 days. And then another 87 underwent echo due to routine clinical care. So what happened to those other patients? Not surprisingly, of those 1,100 patients that we called, there were maybe 400 patients where we texted the patient and then we called them 3 times over the course of a week, within 24 to 48 hours of when they had been discharged from the emergency department or the hospital. And there were over 450 patients where we were never able to even get them on the phone. And so there's a real challenge here of even when you find out these pieces of information, can you get these patients connected? There were another 250 patients who we had booked for an echo who either no-showed or had been rescheduled at the time of interim analysis. Amongst AI intervention, about 50% were positive for a new diagnosis of structural heart disease and had a class 1 or 2A change in clinical management. And we're obviously following patients out to 365 days and comparing these patients to a control arm to determine it. But to kind of put this in context, over a 9-month period, the EchoNext program ordered more echoes than any single provider at NYP. We had the highest rate of positivity of any provider at NYP for first-time echoes. So on average, first-time echoes are positive for a structural heart disease diagnosis about 30% of the time, and ours was 50% of the time. We never met any of the patients before ordering the echocardiogram. And overnight, I became the equivalent of the 5 highest RVU generating cardiologists as far as new referrals into the system. And everyone just kind of got confused. Then they're like, what are you doing in clinic? And I said, nothing. This is the EchoNext program. There were a number of kind of findings from this. So the first is opportunistic screening is hard. And yields can drop very quickly due to all the logistics of patient outreach. And so, for running the actual randomized control trial now, over the course of this next year, we've learned a lot and we feel much more prepared for that trial. Getting patients plugged into care after diagnosis is just as difficult as getting them to diagnosis. I think we all know that. The issue here is we have all of these patients who are showing up with like palpitations and shortness of breath, not otherwise specified, who frankly don't need to see a cardiologist. And there's a real question here of could we decant the patients who see a cardiologist by having a system in place where a patient shows up in the emergency department or a primary care doctor's office. They say, yeah, I think you should probably see a cardiologist. And before they even get to a cardiologist, depending on what the indication is, you can run the EchoNext algorithm on them, get the echocardiogram done, have that echocardiogram auto-interpreted for whether or not they're positive for disease. And then the patients who are positive for disease go on to see a cardiologist. And now that you have a diagnosis, you can actually send the heart failure patients to heart failure, send the valve patients to the valve clinic, and so on and so forth. And then have those patients who are negative say, hey, we don't think that you need any further follow-up at this time. We're here if you want to discuss these results, and allow yourself to get rid of all of those patients who otherwise don't need to see a cardiologist and open up capacity for those patients who do need to see one. And this is something that I think has the potential to be really transformative of changing what the front door of cardiology is. And fundamentally, I think it functions like a biomarker the way that a troponin or an NT-proBNP does, which is for all of these patients where we're trying to determine whether or not they should get an echo because they have palpitations or shortness of breath, or a variety of other diseases, or a variety of other symptoms, excuse me. This helps clinicians before they get to a cardiologist determine, yes, it's clinically appropriate for me to get an echocardiogram on these patients. We also had a number of world firsts. We had a patient who showed up with a broken hip, who was on the orthopedic service. Echo Next told us to get an echo on that patient. They ended up having severe aortic stenosis. They were completely asymptomatic from it. They had no prior diagnosis, and this led to the patient needing to get an urgent TAVR before they went for hip surgery. And that patient ended up getting, the world's first AI-detected case of severe AS leading to a TAVR. We've had numerous cases of patients with severe mitral regurgitation, otherwise being missed, that was captured, leading to mitral valve annuloplasty and replacement. And as of 7 weeks ago, we just discovered this. There was a 45-year-old patient who showed up after being exposed to smoke in fire, who was short of breath, showed up in the emergency department. And they determined that they thought it was asthma, and they sent him home with an albuterol inhaler, and no further follow-up. Echo Next told us this patient was extremely high risk, so we ended up getting an echocardiogram on that patient 2 days later. And they had an ejection fraction of 10% and severe mitral regurgitation. We sent the patient back to the hospital and notified the heart failure team. That patient was ultimately discovered to have a lamin mutation. Patients with lamin mutations, 1 in 4 of them present at autopsy from sudden cardiac death. So they have a 1 in 4 chance of dying before ever reaching diagnosis. And that patient actually underwent heart transplant a few months later. And so this is the world's first case of AI detection of heart failure leading to a heart transplant. And we're excited to soon present those results in a publication as well. And so this is a really exciting moment. These are not cherry-picked cases. There were over 200 patients who had a new diagnosis that would lead to a class 1 or 2A change in management, just in this pilot trial. And it's very clear to us there are going to be thousands more. This technology is now actually going to be an FDA cleared technology in about 4 months. And we've been working with a number of partners across the country. And so this technology will be in 10 health systems, and then ultimately commercially available for use, because we really believe that this is going to be super crucial for helping change the care paradigms that exist in healthcare. So I come back to that original story that kind of started me on this path. And the thing I'm never going to forget is that you can't treat the patient you don't know about. I really do believe we take phenomenal care of patients as cardiologists. The question is, how do we get to the right patients at the right time? And I think that AI-based opportunistic screening is going to fundamentally change the way medicine is practiced. And I think the development and validation of these technologies is happening today, and it's going to be much more impactful than we may have originally thought. The fundamental question for us as a profession is, are we willing to reimagine the work itself? And can we imagine these new care paradigms? And do we think they're going to be beneficial for us as cardiologists and for patients and for ultimately the health of this country? So thank you so much. Really appreciate being here, and honored to be able to speak with you all. And hopefully we have some time for questions.
Well, thank you, Dr. Elias. That was a phenomenal talk, and I think we all learned a lot. That was really great. I mean, we can open up questions to everyone in the chat if they want to weigh in or raise their hand, to jump in, if they have any questions for follow-up. I guess I'll start with one question. I know a lot of it, you had mentioned some challenges of reaching the providers for these projects. I was wondering what your feedback had been from some of the providers who are involved in this project, and if they had any concerns. But I can imagine a primary care doctor, if an order is ordered without a cardiologist involved, they don't want to be held liable per se with an abnormal testing result, and kind of how we can improve as a community in some of those communication efforts.
It's a great question. Thank you so much. So let's look at some of the different projects. So Echo Next as an example. So there's an ECG, you think it's high risk for an echo. Oftentimes, emergency room docs, they don't want to be involved. If you say, hey, I'm going to take responsibility of it as the central coordinator, as a clinician, they're like, great. The same thing oftentimes, I think, for primary care docs or someone like a urologist. They're like, okay, you think something's wrong, but you're going to take care of it and you're going to own responsibility and you'll order the test. Great, go nuts. Then let's take like one step up to like cardiac amyloid. You know, you can imagine if like what you tried to do was give an alert to a primary care doctor saying, hey, I think this patient has undiagnosed cardiac amyloidosis, and I think you should order a technetium-99 pyrophosphate scan, which you've never heard of before and involves radiation. They're going to be like, what the hell are you talking about? Like, get away from me. And, there, because those were patients with ECGs and echoes, those patients had cardiologists, right? So then it's a little more sensitive, which is like, are you telling me I missed something about my patient? And so there, it was really important, one, to work with the cardio chiefs and then work with like the local heart failure specialist, right? So, working with Parag at Cornell, right? And working with Jun Woo at Queens and all of these different people. And basically having a system in place being like, hey, the heart failure person thinks this thing may be going on. They're happy to order the test and the like. And it was really important also to work with the local communities and like the local practice, because one of the things learned early on, like when we first started the trial, we said, hey, a doctor would say, yeah, feel free to reach out to my patient and consent them for the trial and all these sorts of things. And we would tell the patient, hey, we'll pay for your transportation and we'll give you $100 to come in for the study. You just have to come to Columbia. Asking someone in Queens or Brooklyn to come to Columbia in northern Manhattan, you may as well ask them to go to the moon, right? They're like, not a chance. It's really like, it's totally understandable, right? These patients are 60 or 70 years old. They're like, I don't know what Uber is. Who's going to call me a cab? How do I know it's picking up and things like that? Making it where they were like, you're already plugged into care there. You can get the PYP scan done locally was super crucial and really important. And so, more than half of our patients came from, the other sites. And so that was an important learning. The last one is like with the echo work, the Delineate trial I didn't talk about that much, but it was Delineate is where we review the echoes by AI, and then where we think there's a discrepancy in like MR, AR, TR, we have it. That's also tough, right? Because someone read this echo and then you're telling them, hey, I disagree with it. So, one, we try to tell people like, this is not an indication of your thing. We know this is hard and we know there's variability. The AI model flagged a case that we thought was worth being blindly adjudicated. And for the purposes of the trial, we're having three of their colleagues blindly adjudicate the echo and things like that. That's not sustainable post-trial. We'd probably have to go down to like one clinician. But telling people like, listen, it's way better to find out this way than, something happened from like a litigation standpoint years down the road, right? Like you can read now and you can read with like, hey, there's backup. And like, if something does seem like there's a discrepancy, AI is there to help. And then we can get these patients. And we've already had a number of cases where we've significantly changed the read. American Thoracic Society just happened. Arnar and his resident just presented the first case where it got called moderate MR. Woman already had a borderline EF of 45%. She'd come from 2 hours away, been referred. We called it moderate. AI said, no, this is severe. It got reread, and they're like, this is severe. We need to bring her back for a TE. She had torrential MR, and she had more TR than was originally assessed. And so she ended up undergoing mitral valve replacement. And we just published that in Annals of Thoracic Society. So there are real patients to be helped here. And I think it is super crucial. Like, you've got to show people respect. You've got to say, like, this is not here to make your life harder. This is not here to put you at like increased like risk. This is really here to like help a patient in a thoughtful pattern. And there can be centralized screening models where one person, handles the bulk of the work and then just notifies people when it's positive and they're ready for referral to cardiology.
I think, Dr. Elias, there's a question in the chat as well. How do we send you an EKG for interpretation?
um, uh, I would say get in touch. There's nothing we can do today, but over the course of the next 6 months, I can't announce all of the things, but one, this will be an FDA cleared technology in the next 6 months and commercially available. And then we're working on it and things like that. But there may be something that you use this week where you'll be able to run this technology on it. And keep in touch, and we'll hopefully be able to announce that.
Can I ask if you've used EKG interpretation in kind of rare diseases yet as well, and kind of what the results have been from that perspective?
Yeah, it's a great question. So, like, there's this challenge here. Like, a lot of the models that have come out in the last couple of years, like maybe people on the call have heard of like Viz, Anumana, Tempest. So they have like low EF algorithms, and then there's like a hypertrophic cardiomyopathy algorithm as like an example. So there's this balance here. So one issue is like if you're just looking for that rare disease, the underlying prevalence of that rare disease is so low that even if you have great sensitivity and specificity, your positive predictive value is like not great. Like if we take, let's say you wanted to like look at, screening EKGs for hypertrophic cardiomyopathy, and the underlying prevalence is like 0.2% of the population, you could have an odds ratio of like 10, which is pretty good, and you're still ending up with like a positive predictive value of around like 1 to 2%. And so like would you send 50 patients to an echo to find one new case of hypertrophic cardiomyopathy? So the reason we built the model we built it in the way that we built it was we said, what are like the bulk of the diagnoses that we make? We're missing, we don't have like tricuspid stenosis or pulmonic stenosis or things like that. But what are like what are the kind of like the meat and potatoes? And what if we combine them all and we said, rather than trying to differentiate, this one's aortic stenosis and this one's heart failure. And it does give you individualized predictions. But if we really try to emphasize to people, the question here is echo or no echo. Then you're looking at an underlying prevalence of disease that's much higher. And so you can get to a thing where you say, I can't tell you with great certainty that it's aortic stenosis versus mitral regurgitation versus heart failure, but I can tell you something clinically meaningful is wrong with that patient's heart, and 50% of the time I'm going to be right. And we found like over time and iterations, like that's the right way to do it. Because like that's the thing I think as clinicians we think a lot about, right? Is like if I send this patient for a test and the first 4 times you send them, they're all negative, you're not going to order it a fifth time. And I think that was what we felt was super crucial. It's surprising how well it does work for things like cardiac amyloid, which is like a surprisingly rare disease. So like you can find needles in the haystack. And just like you have to find places where you really think like it's clinically actionable. And like no one wants some sort of like risk, like no one wants a risk score that's like, hey, this patient you're taking care of, they have a 7.2% chance of 1 year mortality. You're like, what do I do with that? Like that's not attached to a guideline. That's not attached to a next step. We really try to build stuff where we say, hey, by the way, this patient was not otherwise being considered for cardiac amyloidosis, high risk that they have the disease, and this is patient's clinically actionable. Think we should get a PYP scan on them. And then, a doc can look at that and be like, yeah, I agree. And that to us is the litmus test, is like, it should really be the next step in the clinical decision should be not controversial to any doctor you're talking to. They should feel like they get why this makes sense and why this is beneficial to the patient.
I guess for our last couple of questions, a couple people brought up related questions. I guess one is, should we develop an artificial intelligence department within cardiology in the hospitals of tomorrow? And then sort of going along that, what advice do you have for trainees as they think about this topic in cardiology?
Oh, those are great questions. To the first one, we need people who are close to the problems. Like we all know this, right? Like everything is death by committee in our hospitals and health systems and stuff like that. At the end of the day, the super crucial thing here is what is the problem and does AI actually help solve it? So for anyone who's actually interested in this, if you just type in my name, one of the first things that should pop up is my lab website. You scroll down to the bottom, there'll be this thing, interested in machine learning and data science. Start here. And you click it, it'll take you to a Google Doc. That Google Doc has like a bunch of resources for like best like machine learning courses and things like that, like awards for junior people in cardiology that you should be applying to. And then the last page is my 5-question framework. So anytime you can imagine like, 0 to 17,000 times a week, someone's like, I've got an AI idea. And then, I've just created a framework of like, okay, is this a good idea for using AI? And basically, I just break it down into these 5 questions. So I recommend that. For all people, whether you're a trainee or you're a clinician, here are the things that are important. The version of AI that you are using today is the worst version of AI you will ever use again. We are used to Epic. Epic kind of sucked 10 years ago and it still kind of sucks. Now it just happens to be on our phones, right? Like we're just like not used to rate of change in healthcare. The rate of change for modern AI is mind-blowing, really. And I say that as someone who's been like a researcher in this field for over a decade. Maybe it can't do something today. You cannot presume it won't be able to do that again in 6 months' time. You really have to perpetually revisit these things and not make like static assumptions or static conclusions about them. Um, Secondarily, um, read about what people are doing, understand like where you think it can be helpful. And lastly, deeply understand your problems. Like AI is a tool, but like a tool is only as good as a problem. There are a lot of people out there who are like hammers in search of a nail, right? Like you're going to get a bazillion people pitching you, well, let's AI this or AI that. But you really have to start with like, is this a meaningful problem? Is it tractable? Is there a reason we should be using AI? All of those sorts of things. And there's a great Amos Tversky quote: "People waste years because they're not willing to waste hours." And it's like waste the hours thinking deeply of like, is this actually a good problem? So of the 100 ideas we've come up with over the last 6 years, we have meaningfully pursued 4. And so the number one hardest thing about my job is saying no to most things because all of this stuff is really hard. And so we just said, like, what are the things that are going to actually stand the test of time? And presume the same thing with your own work. Presume, even if AI is super cool and it's great and it seems like it's really exciting, presume actually getting to a point where it solves some pain point for you is going to be hard. And so, like, are you willing to, is this a good enough problem where you're willing to put those hours in? And then just be open to practicing cardiology in new ways. That's the last thing, right? Is, you don't have to fundamentally change everything, but I do think like we want to be in the driver's seats. Like I don't want administrators or people in Silicon Valley deciding how I'm supposed to practice. And so what that means is like we have to be the ones to have a seat at the table and say, listen, I think there's a better way to practice cardiology, and this is what it looks like. And so that's my last take, and it's why I do this work.
Well, thank you. Thank you so much. We're so grateful for having you here. And there's a lot of great comments just appreciating this lecture. So thanks so much to everybody. And I hope you have a good day.